All right. What does the respiratory system do? Mostly it brings in oxygen and it lets go of CO2. Yeah, the lungs play a part in converting angiotensin 1, angiotensin 2, and all that, but the primary role of the respiratory system is to oxygenate the blood and rid the blood of CO2. Well, you got a question? No. Oh. I'm trying to follow it. Oh, okay. Yeah, so that's it. That's it. The upper respiratory is going to be basically from here, from the trachea up. So your sinuses, your nose, your mouth, your throat, your pharynx, your larynx, your voice box, your trachea, your windpipe, and then the trachea splits off into the main bronchi. Your lower respiratory system is going to be your bronchi, your bronchioles, which are the little tiny branches, and your alveoli. So here's the upper respiratory. What does it do? It pretty much warms the air before it gets to the lungs and prevents infection pathogens from hopefully getting to the lower respiratory tract. You got hairs in your nose, cilia. You have hairs in your nose to hopefully catch things before they get, to your respiratory tract. You have your tonsils and adenoids. All these things are supposed to protect you from invasion into your respiratory tract. Here's just some more pictures so you can see where your sinuses are from a side view. The frontal sinuses are here in the front, maxillary in the cheeks. Ethmoid is here, right where your eyes and nose meet, up in here. Another picture, just in case you weren't clear on what I just said. Here they are, the sinuses. All right, sinuses are just empty cavities in your skull. So they tend to get, if there's inflammation or whatever, it's a good place for mucus to collect and then cause inflammation and infection. Obviously, we know most of us were born with 2 lungs. The right has 3 lobes, left has 2. The pleural sac, your pleural space, your lungs are inside of a nice sac, okay? That's your pleural space. This is your pleural cavity or your thoracic cavity. And that's pretty much all you need to know here, because I'm going to go on to talk about these. The alveoli, these are a very important part of the respiratory tract. This is where the exchange of oxygen and CO2 takes place in the lungs. So back on that first picture, if it will be so kind to allow me. All right, so, oops, sorry. This picture here, here's where the alveoli are on the ends of the bronchioles. You have the bronchus, right and left main bronchus, and then they break off into smaller branches, the bronchioles, and then they terminate in the alveoli. They look like little grapes. Now, blood. How does blood come to the lungs? From the heart. In an artery. All blood that leaves the heart leaves in an artery. Arteries bring blood from the heart. So when the blood comes from the heart, how's it coming? Oxygenated or deoxygenated? Deoxygenated. The pulmonary artery leaves the right heart, and that is the only artery that is not carrying oxygenated blood. And the pulmonary veins return blood to the left heart, and those are the only veins carrying oxygenated blood. So it's reverse. Why? Because obviously the oxygen is coming in at the lungs, okay? The lungs do the workload of oxygenating the rest of the body. So if I have a long-term problem with my lungs, what side of my heart is going to affect? Right. When there's something wrong, everything goes backwards. Okay, so remember, like with the portal vein, When something's wrong in the small intestines, blood starts backing up the portal vein, then you end up with this portal venous hypertension, esophageal, everything starts going backwards. So if the heart is bringing blood to the lungs from the right side, if the lungs aren't working the way they should, traffic's gonna back up, okay? And blood's gonna go backwards. And because of that, it's gonna lead to increased workload on the right heart. So long-term lung disease, chronic lung disease leads to right-sided heart failure. It's called cor pulmonale. Cor pulmonale. You'll see that in your book. That is the name of right-sided heart failure caused by diseased lungs, okay? Cor, C-O-R, and then pulmonale, P-U-L-M, pulm, which means lungs, O-N-A-L-E, cor pulmonale. It's in your ATI book, it's in your Lippincott. Right-sided heart failure is related to lung disease. Left-sided heart failure is all the other stuff, but right-sided heart failure is related to lung disease. You'll need to know that throughout your life, throughout your little nursing student career, and so on and so forth. Here are just more pictures of the lungs in case you didn't get it the first time. Ventilation. So remember I was talking about the diaphragm. The diaphragm contracts. It's up here up under the lung. It's going to contract and go down, causing negative air pressure, negative pressure in the lung. Negative pressure, when you think of negative pressure, think of a vacuum. Just like if a patient has TB, we put them in a negative pressure room. Why? Because basically the vent is like a vacuum. It's not blowing air in, it's sucking air out, okay? So when my diaphragm goes down, my lungs are able to suck air in. And then when my diaphragm relaxes and goes back up, it pushes the air out. So the diaphragm contracts and the lungs expand, the diaphragm relaxes and the lungs deflate, and we expire air, not expire die. Okay. So because of this, anything that is going to cause muscular weakness, we just talked about this with the electrolytes, anything that's going to cause me to have generalized muscle weakness could potentially affect my ability to breathe. If my diaphragm is weak, if I have a neurological disorder like myasthenia gravis or a million other neurological disorders you could think of that cause weakness, I'm going to be at increased risk for infections and decreased ventilation and perfusion. My lungs aren't going to work as well if the muscles cannot do their job. It's also going to be a sign of distress if I can look at my patient and see those muscles working. You have muscles here, your intercostals, in between the ribs. If you see, and I'm going to show it to you, this PowerPoint has so many pictures. If you see intercostal retractions, if these muscles, if you can see them sucking in and going out, that person's in distress. That is a sign of respiratory distress. If I'm seeing their abdomen going in and out, not on a baby, newborn babies, that's normal. They're just brand new. Their little diaphragm is brand new. That's just, they got to compensate, okay? They're just little babies. But anyone else, abdominal breathing is a sign of distress. So if you see the abs, like the abs we trying to work out when we do our crunches, if my abs are having to work to help my diaphragm, if my intercostal muscles are having to work real hard, that alone is a sign of respiratory distress. You would document that. You would document the patient, is complaining of shortness of breath, appears to be in distress with use of accessory muscles. Those are accessory muscles. They shouldn't be doing any work, but now they are because the muscles that should be working are not. So use of accessory muscles, intercostal retractions, those are terms you use to describe someone. If you see that, that's a sign of distress. So when I'm assessing my patient and they're coming in with respiratory complaints, of course, history first. I got to get the subjective data. What's going on? What is the symptom? Oh, you have a cough. Okay, when did the cough start? How is it getting worse or better? Is it dry? Is it productive? If it is productive, what color is the sputum? Is it clear? If it's clear, it's probably nothing to worry about. But green, yellow, any discoloration, is it bloody? Hemoptysis, that's a sign of tuberculosis. That's a sign of lung cancer. Shouldn't be coughing up blood, okay? So those kind of things. And again, asking them about the secretions. Do you have a runny nose? You know, do you have ear drainage, whatever? So many weird things that Kevin. What is the consistency? Is it thin secretions or is it real thick? Sometimes that stuff is so thick, they can't cough it up, and now you need to tell them drink more fluids or use a humidifier. Are they having a fever? Because now we know it's probably an infection, right? Shortness of breath. Are they having chest pain? That can tell me a lot. Because are you having left-sided chest pain that's radiating to your arm? That could be a sign of a heart attack. Because if something's going on with the heart, it's going to affect my breathing too, right? Or are you having just chest wall pain or pleurisy, just pain here, you know, in between the ribs? Another thing, costochondritis. Don't write this down, but there's a million other things that could cause chest pain. Costochondritis is just inflammation of those muscles in between the ribs and the tissues in between the ribs. It's a very common complaint of chest pain. You have to look at the whole picture. If your patient's 19 and has no freaking medical history, maybe they are having an anxiety attack. Maybe they aren't having a respiratory issue. Maybe they need a chill pill. So you have to look at the whole picture. And that goes with their medical conditions, injuries. You know, I need to know if I'm listening to your lungs and I don't hear anything in the right lower lobe, I go call the doctor. Oh my God, he's got absent breath sounds in the right lower lobe. I don't want to be told, well, he had his right lower lobe removed back in '83. I don't want to, you know, so you got to do an investigation for it first. Assess first before you jump to conclusions. So that would be need to know information. If you had lung surgery before, if you had a pneumothorax or something before, that would be a risk. Now this patient is more like emaciated, but you can, this is what I'm talking about when you say the intercostal retractions. When you see those muscles going in and out while a person is breathing, they're working very hard to breathe. Their breathing is labored. They are putting in too much work. Patients with COPD. When you become comfortable and you see these people all the time, you'll recognize them. I watch TV all the time, like, damn, that lady got some bad COPD. Just look at her. Listen to her voice. They get hypertrophy of these muscles and things. There's things I can just look at you and see right away without ever pulling out my stethoscope. Are you able to speak? If I'm able to sit here and lecture for 2 hours, and then I tell you I'm feeling short of breath the whole time, are you probably going to believe me? Probably not. If you're able to carry on in conversation and speak in complete sentences, you're likely not in any distress, right? I love when patients scream at the top of their lungs. I need girl, what the hell? Just shut up. Say the shut up. You can breathe, okay? An ominous sign or a red flag is when if any of you guys have asthma and your kids have asthma. I mean, when you got someone, you will say, are they speaking in short phrases? Like maybe they can say a quick sentence, but they can't say a whole paragraph. Or can they only give you a one-word answer? You got to watch, especially little kids. Be worried when the kid's not saying anything. That's because they can't breathe. Or maybe they have an obstruction in the airway. So how they talk, looking at their fingernails, clubbed fingernails. This is what they look like. That is a sign that this person person has been living long-term with hypoxia. This doesn't happen overnight because I had pneumonia for 2 days. This happens from chronic hypoxia. My oxygen's been low for a long time. Now I got these ugly alien fingers. Skin color. Skin color alone. If I'm looking at you and your lips are blue, I'm probably gonna be a little concerned. Why are your lips blue? Like this lady here in the bottom. What's that called? Cyanosis. And when you're looking, this is the best place to look. The oral mucosa. Central cyanosis. If this is going to be much more reliable than I live in Chicago and it's 13 degrees outside and my fingertips turn blue. That can happen. It's cold as heck outside. But this, looking at their face, at their oral mucosa, that's assessing for central cyanosis. And then again, their effort. You could see if they're using accessory muscles. You could see if are they grunting? Are there babies, nasal flaring? Are they trying to, that is a sign of respiratory distress in babies. Nasal flaring, grunting, because they're not going to be able to tell you they're short of breath. You're going to have to see it. Positioning, what is the position that a COPD is going to sit in? Tripod. So I'm going to be sitting like this. I'm going to think about it. If you play sports, I used to play soccer, right? After I run up and down the field and I'm short of breath, what do? It's your body's natural. That is your best way to open up the airways for yourself and blow off the most CO2. Blow off the most CO2. The inspiratory phase of breathing is much shorter than the expiratory phase. I breathe in a little bit, but I breathe out a whole lot. And as people get COPD, it gets worse and worse. They're able to breathe in a little bit, but not able to blow out a whole lot. Or they're having an extended expiratory phase. Examine the airway, right? I'm gonna look at your mouth and make sure you didn't choke on a quarter. And then assessment of the lower respiratory structures. You're gonna listen, or maybe do the egophony and all that stuff. All right, breath sounds. So I want to pull up these breath sounds. Who up here talking? Whitney sound like you at the hospital already. Shift around the machine going off. Check the IV. Something ain't going right over there. All right, so lung sounds, right? Normal breath sounds. Over the bronchioles, you're gonna hear bronchial sounds as you get closer. Whenever you hear the term vesicular, that's talking about an organ. Not specifically the lungs, but vesicular or visceral, they're talking about an organ. So as you get closer to the lung tissue, then that's the vesicular sound. To be honest, they all sound the same, okay? Doesn't sound like clear air moving through. It's gonna get a little bit lower pitch when you get to that area, but I would not obsess myself with trying to figure out the difference between bronchovesicular or vesicular sounds. Just know those three are normal. Normal, everybody's listening to somebody's lungs, right? I know you did when you got that stethoscope fresh out the box. She was walking around the house. Let me listen to your lungs. Come over here, kids. You want to whoop it? I'm going to listen to your lungs. You better listen to your lungs. Right, I swear. Look, let's put this thing to use. Yeah, get over here. Hey, I remember when I was going to nurse practitioner school. You know, and you had to do a real head-to-toe assessment, shine the light, look at the ears, all that. And I had to bring my boyfriend to school. And he had to be in just shorts, no shirt, no nothing. And I had to do a full head-to-toe assessment in front of my teacher. And, man, we were practicing so much, me and my boyfriend almost broke up over that pen light, over shining that light in his eyes. He was like, man, I'm about to sick of this. How many times you gonna shine this sun in my eye? I was like, you don't care about my education. the nurse's stool, you know, gets a
That's
little
right.
stressful. Gets a
Gets
little
better
stressful.
though. Okay.
Yeah. I just got a new man, that's all. I got a new man, that's all I did. Oh, you don't want me to shine? I know somebody that will. My man got a brisk pupillary response. Don't you worry, I know somebody who will. So the lung sounds, right? We know normal. I'm gonna just play normal lung sounds. Everybody knows what normal, clear lung sounds sound like. Oh, hold on, I'm breathe. Normal, clear, normal, in and out lung sounds, right? Yeah. But now here's crackles. That sounds like wheezing.
That sounds, somebody
But crackles, it sounds like crackles and wheezing, but you hear the crackling? Let me play it again. The first part. You hear the crackles at the beginning. It sounds like, don't worry, you ain't gonna be no lung sound expert. But anyway, crackles, it sounds almost like Rice Krispies in when you put the milk in and it starts a little bit of crackling. That's, yeah, snap, crackle, pop, little snap, crackle, pop. That is a sign of what? Fluid in the lungs. If you hear crackles, then it's fluid. Wherever you're listening, there's going to be fluid. Rhonchi, wheezing and rhonchi. Narrowed airway. It could be narrow because of fluid. It could be narrow because of inflammation and swelling. But wheezing is going to be more high pitched. Rhonchi is just coarse wheezing. So here's wheezing. Sounds like a whistling, right? High pitched whistling like a train. That is air trying to travel through a very narrow airway, okay? And then rhonchi is just lower, same sound, just more low pitch, yeah. Coarse. What's that? You hear it?
He's snoring.
You hear that? So that's like coarse wheezing. And then the worst sound you could possibly hear, no sound at all. Absent. If I don't hear anything, that means no air is moving through here. That's the most alarming sound you can hear. All of these, I mean, any of the abnormals, you're going to be alarmed. But when a person has absent breath sounds, you really need to be worried. They have no air moving. Someone can have that's how it starts, asthma attack. You're gonna hear wheezing first. As it gets worse, you're gonna hear that coarse rhonchi. And then eventually, as they start getting tired out, they're still breathing, but no air is moving, none. You won't hear anything. That is a sign that person is gonna need probably like high flow oxygen, or maybe even nearing towards respiratory failure, and I need to be alarmed. The last one, the friction rub. Let's see how that sounds.
That one, like, there's inflammation?
Yeah, it's inflammation in the pleural space. So let me get these Zoom people up in here. Let's see. Oops, let me go back. Wait, get on the screen. All right, go. How do I go back? Oh God. Oh, jeez. Present? Okay. Where is it at? Okay, I just wanted to show you. Again, the pleural space, and we're going to talk about it. So when there's inflammation here, because this is a nice sac, I said, the lungs sit in this sac. So when somebody says, oh, their lung collapsed or whatever, it's not like you just poked a hole in the lung and it collapsed. It's usually pressure in this space causing it to collapse. So when this is inflamed and you have the lung rubbing against that, then that's pleural friction rub. All right, moving right along. Pulse ox. So everybody knows what this is, right? Pretty sure you do. They sell these things at Walgreens and stuff. But pulse ox, non-invasive, it's gonna give you a quick read on how well the hemoglobin, the red blood cells carry the oxygen. So how well are they saturated with oxygen? 95 to 100 is the normal, but of course it could be much lower for someone who does have chronic lung disease. It could be 90, it could be 88 even if you have more advanced COPD. But normal, usually 95 to 100. Now this could be very unreliable. It is nothing like an ABG if it's coming out of your artery, that is the most accurate way to look at somebody's oxygenation is the ABG. Because look, I mean, this thing can slip off. The baby's already pulling it off his foot, it's dangling on his ear. It's just so many variables that can make this abnormal. These are all different ways you could check it. Doesn't just go on your finger. And for a little tiny newborn or infant, you're gonna usually wrap it around their foot like that. This is much more accurate than this, again, because your hands could be cold, the circulation. They have to have good circulation for this to work. They could have nail polish on, like Alexa said. They could have just them big old club fingernails with nail fungus on top of it, and it's just thick and gross, and I just can't get a read. They could, Bon Queen could be coming with her acrylic nails. So just so many variables. Obviously, you're gonna remove the polish and all that. Don't just, again, look at the patient. If I put a pulse ox on you and you came here for chlamydia or gonorrhea, Gallo's favorite subject, if you came here for gonorrhea and I'm just doing basic vitals and your pulse ox is 76% and we're just talking, don't pick that phone up and call the doctor and tell him the pulse ox is 76%. The girl's a god. She has her fingernails painted black. You need to look at the bigger picture. Don't just look at numbers and start doing stuff. I told the students a story yesterday. I had a nurse call me at 5 o'clock in the morning. Now I see why doctors snap. Call me at 5 o'clock in the morning to tell me, what you say? The patient is saying he doesn't feel good. He's short of breath, and I can't get a pulse. You can't get a pulse. I said, so are you doing, what are you calling me for? Do CPR. No, I can't. It's not reading. I can't get a pulse. What do you mean? What's not reading? What is not reading? Oh, well, she put the pulse oximeter and she couldn't get a pulse.
Oh my God.
I'm about to quit this job because I'm about to cuss this whole. All right, look, if you put this on and it's not reading, then I'm going to maybe assess your carotid, your brachial, your radial. There's so many other places I could assess your pulse without my pulse oximeter. In fact, maybe just take that fancy stethoscope off from around your neck and put it to the patient's chest so you can listen to their heart. But no, not you, rocket scientist. You picked up the phone at 5 a.m. to call me to tell me that basically you were having an issue with your pulse oximeter. This is that stuff that nurses do all day, every day. Don't be that nurse. Don't you be that nurse. Now these tests, pulmonary function test. All you need to know is a test looking at the pulmonary function. It's a good way to assess for asthma, period. You don't need to know anything more than that. Why? Because you're never going to do this test. It is a test performed by respiratory therapists. It's a test performed at the pulmonology office. It is nothing you need to know as a registered nurse working on whatever floor you're on. Even reading the results, you're never going to be able to read those results. You're not a pulmonologist. So don't even worry your little brain trying to learn the ins and outs of a pulmonary function test. Chest x-ray. We all know what a chest x-ray does. It looks at the lungs and everything else. All you need to know about that, what? Make sure you're not pregnant. Make sure if you're of childbirthing age, if the nurse needs to be in the room with them, or maybe you're doing the chest x-ray on a baby and mom needs to be in the room. Lead apron. That's pretty much it. All you need to know about an x-ray. CT, we already just talked about it with the last exam. Make sure they don't have a shellfish allergy. Make sure they don't have an iodine allergy, and make sure they have good kidney function. CT is a CT is a CT. An X-ray is an X-ray is an X-ray. Doesn't matter what part of the body you're doing it on. Now the results, of course, matter, but the test itself, I mean, they're all the same. MRI, you're gonna assess for what? Anybody know? You're gonna assess one, metal implants. If the client, this is a super duper strong magnet. Now, it is 2021, they make real high tech MRIs now, but for classic textbook, not you go work in Okeechobee, they probably ain't got nothing high tech. So, for an MRI, you need to make sure they remove all jewelry, and you need to assess, do they have any metal implants? These days too, now they don't use metal. You know, they know, or they use stuff that is safe for an MRI. But back in the day, if you have a metal implant, you go for an MRI, you can snatch that pacemaker right out of your chest. That's how strong that magnet is. So you need to assess for metal implants. If they got shot back in '93, don't blame me. I'm just from Chicago. I quit everything. If you got shot, if you got shot in '93 and you still got that bullet, make sure you know that as a nurse before you send that patient down there. You can have want to have a flashback real quick. Snatch that bullet out your way. Assessing for allergies again, because they're going to get IV dye. Claustrophobia. A lot of people, when you get an MRI, it is a long tunnel. A CAT scan is just a donut. Table goes in, pulls you back out. MRI is like a long tunnel. The tests usually take at least an hour, and it is noisy as heck. They offer you, I don't know, I guess I went to a low budget place for my MRI because they just gave me like the basic little earplugs. But now I hear you could get headphones that will play peaceful, soothing music. But either way, you need to know that. A lot of times as a nurse in the hospital, you're going to have to get an order from the doctor for a sedative because a lot of people have, it's America, people, we got anxiety about every damn thing. I don't know what's wrong with us here. So those are things you need to assess for MRI, no matter what part of the body. ABGs, we already talked about that. ABGs, most accurate way to assess the oxygenation of the blood, most accurate. pH, we already know that's the free hydrogen floating around in the body. pH is going to tell me, are they acidotic or are they alkalotic or are they normal, right? PaO2 is just telling me how much blood is available in the blood. How much oxygen is available in the blood. The pulse ox is telling me how much oxygen the hemoglobin is carrying. And then bicarb and CO2, we already know that. Now, you may not, it depends on where you work. I've drawn plenty of ABGs working in the ER, but every hospital, usually the respiratory therapist will draw your ABG. So you don't necessarily need to be knowing about, all it is sticking the needle in the artery. It's not rocket science. But you do need to know as a nurse, even if you're not doing the test, you need to know this Allen's test is performed beforehand. You need to make sure if something goes wrong here in the artery, when I poke the radial artery, they have what's called collateral circulation on the other side. If something goes wrong here, I need to make sure that they still have good blood flow, even if I mess something up over here, you know? So this is what you're looking for when you're doing this test. And I know this is straight in your ATI book. Looking at the blood, you could already tell is it venous or arterial. Oxygenated blood, unless they're in like respiratory failure, oxygenated blood should be bright red, dark, burgundy, dark red like that is usually venous. So if you were drawing somebody's blood, say you started in an IV and blood started coming out fast and it was bright red like that, you're probably tapped in artery. Are they gonna die? No, but once you have tapped in artery, you need to hold pressure, firm pressure for a while. When the patient gets an ABG drawn, the nurse may sit there. The respiratory therapist not only draws the blood, but they run the test. So your RT may come, they may draw it, but then they got to run straight to the lab with the blood. So you may be there holding firm pressure, making sure they don't get a hematoma, a blood collection under the skin. Ice, the blood sample has to be iced once it's drawn. Sputum culture. Sputum culture is another assessment. You're gonna do that to, prior to antibiotics. We already talked about that. It's UTI, I'm gonna do a urine culture. If I wanna know blood culture, cultures come before any treatment, before antibiotics. Sputum cultures best collected in the morning. You wanna get it in the morning, that's when they're, same with the urine, right? The morning, that's when you've been resting, everything is, you haven't eaten or drinking anything to throw results off, everything, the best results come first thing in the morning. You may need to give them a nebulizer or something to loosen up secretion, or have them drink some water. But you want to get it before they eat and drink first thing in the morning. You can tell them just cough and spit in the cup, or if you have to suction them, like if they're they're intubated. This is your PPD. This is your PPD test, otherwise known as, I think it's Mantox, but don't quote me, because I just call it a PPD. That's how you say it? Okay, good, thank you. All right, so you as a nurse will do this test. Medical assistants do this test. You'll do it on each other. When your time, you gotta get it every year as a nurse, so you'll be on there for like, hey, could you just do my PPD real quick, because they're gonna take me off the schedule. So, you insert 0.1 mL, bevel up with the needle, and they return in 48 to 72 hours. You're gonna make a little, you wanna make a little bleb, a little bubble up under the skin. Now, lots of people have allergic reactions to the PPD. Lots of people come back and then just have a little bit of redness. That is not a positive PPD. This is what a positive PPD looks like. It looks like you got burnt with acid, okay? It's not usually painful. It just looks crazy as hell, okay? It's usually not painful, but it is greater than 10 millimeters. It's indurated, hard, firm, swelling, and it usually gets all bubbled up like that. That's a positive PPD. You'll know one when you see one. Having just a little redness, a lot of people are allergic or have reactions to it. Obviously, if that's positive, it doesn't mean that the person has active TB. I think we all know that, right? But we'll talk about TB next week.
I know like South America.
BCG, is that what it's called? BCG?
So yeah,
Lots of other countries, not just one. There's lots of foreign countries. So if your patient is a foreigner, I don't mean to say it like that, foreigner, but like if they were not born and raised in this country, then you do want to ask them, did they ever get that BCG? Because a lot of people from other countries, they don't even get it because they don't want that to happen to their arm, and it's probably going to happen. So just give me a chest x-ray. I don't want that. Because it takes like weeks for that to go away. It looks horrible. It's just ugly as ever. Now, obviously, and then at the bottom, just one more thing, more than 10 millimeters for a healthy person, but if they're immunocompromised, you should even be alarmed if it's just slightly abnormal. You still want to be on high alert because they're high risk. Bronchoscopy, this, just like the EGD, just like the colonoscopy, same kind of idea. They're going in with a camera and they're looking at inside the lungs, right? Inside the trachea, whatever area they're trying to look at. So they're going to be NPO, just like they would for colonoscopy or EGD. They're going to be, this one, they're going to be intubated and they're going to be completely sedated, general anesthesia. The only way I could get that camera in there, I need to put an ET tube, endotracheal tube in your throat. So they're going to be, this is like in the OR, they're doing these. They're going to be on the table laying flat with the ET tube in. My job, I'm not performing a bronchoscopy. And again, likely you're not coming straight out of school to go work in endoscopy. So the questions they're going to ask you usually aren't going to be, what position is the patient going to be in for this procedure? No, because that's not what you're going to school for. You can learn that when you go work in the endoscopy lab. But you need to know about that gag reflex, what to look out for after the procedure. You need to know they need to be NPO prior to. Any invasive procedure, they need what? Informed consent. So you may be the one witnessing informed consent. You're not the one explaining every risk. That's the person who's about to shove the camera in your lung. So assess it for a gag reflex. Throat pain is going to be expected. Just like with the TERP and cystoscopy. Pink blood tinged sputum is going to be expected. You just irritated my throat, irritated my bronchioles. And yeah, that's about it. Thoracentesis. This is one more procedure, huh?
That's Mel's favorite procedure.
Oh, you had it? Oh, your patient at clinical? Oh, okay. You said we had that. I'm like, dang, what happened to you, girl? You had a thoracentesis. You watched it? Oh, they did it at the bedside. Oh, nice. So was he sitting up and leaned over? Yeah. So the patient gonna be sitting up, but they're gonna do it from the back. You gonna lean forward. He was awake for it, right? You just gave conscious sedation. Just numbed it.
Yeah, I just know that she moved a little, so he ended up hitting the rib a little bit, but he knew that she moved, so that he went in.
He moved with her.
Yeah.
He knew what she was moving and that's because he been here before. He did that before.
Since she was 97.
She's 97 years old. No, 95. No, 95. Yeah.
Oh. So yeah, so thoracentesis and chest tube insertion, they may go off the floor for it, but it can be done at the bedside. So you could be asked to assist with something like this. You're not doing the procedure once again, so you don't need to know which intercostal space to insert. That's going to determine, what's going on with them is going to determine that. You're not a pulmonologist.
They asked us that on Tuesday, like we have the test.
They did?
Yeah.
What intercostal space?
What intercostal space is it in?
Were you paying attention?
Yeah, but you're not going to need that. You don't. You need to know, like, if you're checking the apical pulse, fifth intercostal space and mid clavicular line, but that's all you need to know about the fifth intercostal space. For you, you need to monitor this one. You're probably, if you're at the bedside, you're going to be giving them emotional support, rubbing their hair, telling them how beautiful they are. This is going to be over before you know it. You're going to monitor vitals. Now, if I'm going in your chest with a needle, what's going to be what am I going to be at high risk for? Puncture. So you're going to be at risk for a pneumothorax, and I'll show you that later. But yes, the main thing, you're going to be watching them for that. They're going to get an x-ray before and after to make sure. One, did we get out the fluid we even went in there to get, or whatever they went in there to do? Because they may inject medication. They may go in there and inject medication. They may be pulling fluid off. There's a million reasons why a person would have fluid around their lungs. But chest x-ray has to be done before and after. And you need to be monitoring them. The most serious complication is going to be a pneumothorax. So, a couple things. Because when we go through the diseases, it's all the same. I'm trying to prevent hypoxia, hypoxemia, same thing. I'm trying to prevent respiratory failure and death, basically, right? So hypoxemia, that's got inadequate oxygen. What can cause that? Plenty of things. Not just disease of the respiratory system, not just asthma, not just COPD. Like I said before, if your patient had a spinal cord injury and they are paralyzed, especially from C-spine down, if they're quadriplegic, you're going to see them in and out of the hospital all the time because they don't have that muscle, those strong muscles to effectively breathe. So they're going to be at high risk for pneumonia. Brain, anything going on with the brain? Remember when I told you about you could be so intoxicated that you couldn't protect your airway. You could be having a hemorrhagic stroke. If I see someone who's having a stroke and they're grunting and snoring, we're going to get ready to intubate because this person's brain, they're getting so much brain damage that their brain isn't sending the right signals to the lungs to function. Circulation, red blood cells carry the oxygen. So if I'm anemic, or if I just hemorrhage, or my red blood cells are low, my oxygenation is going to be low. If I hemorrhage, what did we say about hypovolemia? They start to have increased respirations, right? If I'm hemorrhaging, I need to start breathing faster because I don't have enough blood to carry the oxygen. So now I just need to get enough oxygen in. My heart rate is going to go up. Why? To help deliver oxygen to the rest of the body with whatever little bit of blood I got left. So there's different things. I don't worry about the bottom part, but what is really causing it could be a million different things. It could be neural, it could be circulatory, it could be respiratory, or muscular. Early signs. Early signs for anything, the body's gonna be trying to compensate. Late signs is the body got tired, can't do it no more. So early signs of shock, early signs of hypoxemia, they're all it's the same. The early signs is gonna be, what does my body look like when it's trying to compensate and make up for it? So I'm gonna start, I'm breathing faster. I'm trying to get more oxygen in. I'm pumping faster. My heart's beating faster. I might start to get restless. I may be pale. But if I start turning blue, I'm out of here. I'm done. Stick a fork in me. My O2 set is probably 70% by this time. Now I'm tired. I'm either confused or I might just be comatose. My heart is tired. Everything just tires out. So early signs is going to be me trying to compensate. Late signs is going to be, I've been doing too much compensating. I'm done. Stick a fork in me. I'm tired. Hypercapnia. This really is where a lot of COPD patients live, in hypercapnia. They have high levels of CO2. Hypercapnia means I'm going to have what? Acid-base imbalance. Anybody? Yes, respiratory acidosis. You guys are so smart. So so it could be from hypoventilation. It could be, again, a number of things. But what is it going to affect? It's going to affect my acid-base balance. It's going to affect my kidneys, right? Because now if I'm in respiratory acidosis, now my kidneys got to work harder to retain bicarb. My nervous system, same stuff I just talked about. And then the cardiovascular function, it's going to cause me to be confused. It's going to cause my heart to have to work harder.